She is a social psychologist who conducts domestic and international community-engaged research to understand and address HIV-related disparities. We also have Dr. Mutchler from APLA Health and Cal State Dominguez Hills. Dr. Mutchler is a professor of sociology and director of Urban Community Research Center at Cal State Dominguez Hills and the manager of community-based research at APLA Health. We also have Sean Lawrence with APLA Health, who has been in the HIV field for 19 years and earned a BA in psychology from the University of Massachusetts, where he took an interest in LGBT issues. He has worked on previous research studies dealing with HIV prevention protocols, including HIV vaccine studies and HIV treatment studies. We also have Damone Thomas from APLA Health, who is a treatment education specialist for the project RISE at APLA Health. He is originally from Kingston, Jamaica, and has been working in the HIV field since 2008. Thank you.
So thank you very much for the opportunity to talk with all of you today. We're very happy to be able to share our research and would love to get your feedback. So before we start the presentation and talk about the research, we wanted to talk about the elephant in the room. And the elephant in the room is that Matt and I are both not from the communities that we study. Even though we've been studying these issues for many years, we still know that we're from a different culture, from different communities, and we're aware of this and want to acknowledge that. So one thing that we know is that sometimes when we speak to community audiences, people wonder, what are our motivations? So why are we doing this research? So is it to advance our career? Is it to help communities? So one thing we wanted to do is first share just stories about ourselves and talk to you a little bit more about where we come from. We do this, excuse me, in a lot of community presentations that we do. Over the years, I've told stories of when I asked for my first HIV test and I was told by the doctor, we don't serve patients like that here. I've told the stories of when I went to the first funeral of a person I knew who died of HIV, and how I was told by his mother that I was the only person who hugged him, and he remembered that because everyone else was too afraid. And today I wanted to tell another story of when I first heard of HIV. And it was in 1980. I grew up in New York, in Queens, New York. And my dad was a doctor in a hospital in Midtown Manhattan near the theater district. And in 1980, I started hearing him talk to my mom about different patients that he was seeing. And I was just in grade school. I didn't really know what he was talking about. But what I heard him say is that he talked about patients that he didn't know what to do with, that it was heartbreaking, that they would come back and he would treat them and they would go away and then they'd come back with the same issues. And they would keep coming back and he didn't know what to do and he felt helpless. But what I heard most in his voice as a young child is I heard how compassionate he was, the empathy in his voice, how sad he was, and I didn't hear any stigma. And that's how I first heard about HIV. So then several years later, when I was hearing more about HIV and growing up in New York, a teenager, and I heard nasty jokes, I heard stigma, and I was almost confused about where that was coming from. Because when I had first heard of HIV, there was no stigma and there was only compassion. And so it made me reflect on how, we can all be role models, and even if we don't know somebody's listening to us or seeing us, just acting with compassion and empathy really can help to fight stigma. So that was something I learned early growing up, and in fact, a few weeks ago when I was preparing for this presentation, I called my dad and I said, remember when you used to tell my mom all these stories about HIV? And he said, you heard all that? I didn't know you were listening that whole time. I didn't know you knew about that. And he couldn't believe I remembered all these details when I was so young. And so it shows that even if we don't know people are listening to us, people are observing, and we can change stigma through that. So thanks, and I'll let Matt tell his story and then we'll start on the presentation.
All right, thank you, Laura. And before I tell my story, I'm going to tell a kind of funny story, because someone told me it's okay to have fun here. I think that was you. It was Sean. So it kind of relates to my story, but I've been working at AIDS Project Los Angeles for going on my 20th year, which is pretty hard to believe. But I feel pretty much like an Angelino now that I've lived here this long. And my story, I think, is one we could probably all relate to in a way that I think we kind of do share a community experience here in Los Angeles. Because we all had to get up this morning and get here early, right? So I don't know about you, but I start planning, and I knew I just had to get up early and get on the road, because even though I live in Culver City, coming out here might as well be like Indio, There's no, it's like, it takes forever. So what I usually do is just get up really early and just get on the road. And I did that this morning, and I just got right in my car, and I thought, okay, I'll figure out where to eat breakfast on the way. And so I'm driving and everything, and I remembered this place that someone who I used to date in Silver Lake took me to. It's called Home State. I don't know if any of you know, it's on Santa Monica, but they actually have breakfast tacos that are so good. So that's something to keep in mind if you're looking for a place. They have breakfast tacos and good coffee too. So, you know it? Okay, good coffee, that's important, right? Yeah. So that's where I went this morning, and then I'm driving over here, on my little GPS and everything, and I passed by this place on Hoover called Cafecito Organico. Anyone been there? Is it good? Okay, because that's where I'm going next time. It's nearby. So anyway, my story has to do with why is it that I'm doing this work? And as Laura said, we feel that this is part of our work, being in the community and sharing our stories as to why we're doing research with African Americans who are living with HIV. For me, the reason I got into this work has to do with what happened early in my childhood. When I was 8 years old, my father died from cancer. He was a helicopter rescue pilot in Vietnam, and he came home, and I watched him die as a very young man, much younger than I am now, actually. And the cancer was from an unknown origin, an unknown source. So obviously that experience has really framed, my life and how I grew up and so forth, and created a lot of empathy. When I went to school, I went to UC Santa Barbara, and I started coming out, realizing I was gay, and at the time, seeing young people who were dying from HIV. And so that became my calling, to try to find ways that I could address and help out in that area, help people live healthier and longer lives. So that's why I do this work. And I think that, it's just important for us to sometimes share our stories as a community and understand why we might be doing work with the community here in Los Angeles. And we're hoping that we can help the Commission reach its goals. In this case, to help people live longer, reach viral suppression, and live healthier lives. So I believe you're next. Yeah. That's the elephant in the room. Hopefully we can say goodbye to it now.
We're happy to talk more about the elephant in the room if anyone wants. So today we're going to talk about our intervention on treatment adherence among African Americans living with HIV. And one thing that we address through our intervention and through all of our work is discrimination and stigma. So I'm going to give a bit of a background about that first. Now, stigma is related to worse HIV outcomes across all stages of the HIV care cascade and related to HIV disparities. And when I talk about stigma, I talk about not just stigma from HIV or discrimination from being HIV positive, but also from racism, from being a racial ethnic minority, from being a sexual minority. So all of the stigmas and identities that intersect with being a person living with HIV. And we found in our work that, and other people have found as well, that stigma and discrimination are related to non-adherence to treatment, disease progression, and worse mental health over time. And one reason for this is a direct pathway, a direct physiological pathway, that when people are stressed, it increases their immune system response, and that can lower immune functioning over time. So that can really affect how people survive and deal with diseases. It can also affect, when people are stressed, they also find it hard to concentrate on things and hard to remember things if some big event, some big stressful event happens to them. So it can also lead to non-adherence just due to forgetting and having a different priority at the time to focus on than adherence to treatment. There are also indirect pathways. So for example, people might cope ineffectively. They might be stressed, and discrimination can be a big stressor in their life. And some people may want to cope through escape, through something like substance use, and doing things that may then lead to non-adherence to treatment because of forgetting to take medications, for example. And we also know that discrimination is highly related to medical mistrust. So not surprisingly, people who are discriminated against within society, within societal institutions like healthcare, are less likely to trust those institutions. So for example, somebody's discriminated at the doctor's office, or they feel like they've been stigmatized in some way, well, they're less likely to go back to the doctor's office, and less likely to trust medications, for example. So what we wanted to do is an intervention that addressed some of these issues, that acknowledged some of these issues going on that affect adherence in people's lives. And when we looked at the literature on adherence interventions, we found that relatively few HIV treatment adherence interventions have shown effects on adherence or viral suppression, especially for African Americans, and especially long term. So they might show recent effects on adherence, but maybe not over the long term, not lasting effects. And we also found adherence interventions are generally not culturally tailored for Black Americans. But in the US, many intervention tests have large percentages of Black participants, yet they don't address or acknowledge these issues of discrimination, of stigma, of medical mistrust. So that's something that we wanted to do in our study. So Matt's going to talk a little bit about the study, Project RISE.
I think I have to raise this up a little bit. We are of different heights, but we are very color coordinated.
Yeah. Not planned.
Well, you did ask me like what you should wear today, but I didn't tell you what color. Laura and I have been working together for a long time, as well as with Sean. And Damone is a wonderful new member of our team. But I think we do get in sync with our work wives and work husbands sometimes. So the purpose is to develop, of RISE, is really not just to develop an intervention, but to study it in the randomized controlled trial to see if it works. And compared to a control or something that's different than RISE, do we see better effects in this program? The program itself was named by our community advisory board several years ago when we started doing more of our preliminary research, and it was named after Maya Angelou's poem, "And Still I Rise." This project, as I alluded to earlier, is consistent with one of the LA County goals to increase the proportion of diagnosed people living with HIV who are virally suppressed to 90% by 2022, which isn't that far away anymore. So just to give you a sense of what is RISE, it is an intervention that's client-centered using motivational interviewing style. So our counselor, and we're all trained in motivational interviewing, but Damone is our counselor, and he uses this style, motivational interviewing, to work with clients and kind of address their ambivalence in a non-confrontational way in order to increase their motivations for adherence and build skills as well. So this is done in a way that he can explore, you know, maybe their concerns about trusting medicine, along with their desires to live longer and healthier lives, and help them build on, hopefully, their positive desires. There are also linkages to social services that address some of the other structural barriers, such as substance use, food, transportation, and so forth. So the question that still kind of drives our research, that we've looked at quite a bit from the literature and from our own studies. How do you make this intervention culturally congruent? And so some ways that we've learned from our own studies and from previous literature and from our advisory board are to address specific barriers, such as the medical mistrust that exists in African American communities, experiences of stigma and discrimination, substance use, and stress that can often come from historical trauma and experiences of racism. That may also lead to structural barriers and poverty. The CAB really felt that it was important for the intervention to be placed in a community context so that these issues could be addressed outside of a medical clinic, where people might feel safer to talk about their experiences. And also that the peer counselors be from the community, and therefore be able to understand the experiences and talk about their own experiences in relationship to some of these issues. So those are some of the ways that RISE has been developed to be more culturally congruent, because the program itself really has a very long history and deep roots in our work here in Los Angeles. AIDS Project Los Angeles had a treatment education program for many, many years, even before I started at APLA. Over on Vine Street, we had a treatment education program. And back in those days, and even earlier, there just wasn't much known about the treatments. But APLA and other organizations were out there trying to help people learn about and advocate, and sometimes even fight for basic treatments. So it was this program that we wanted to look at and see if it was working. So we approached Laura for assistance in developing studies to look at whether this program was working. And originally, we evaluated the existing program through talking to clients and providers and seeing what they thought might be working or not working. And we found that there was a lot of strong enthusiasm for this project, but also a need to really help people develop skills to advocate more for their own health care. So this was developed further with the CAB and APLA health staff. And then we got a small RO1. Some of you might know what that is, but RO1 is a bigger study, but we got kind of a small RO1 to do an initial randomized controlled trial of RISE. And this was found to be effective, but we needed to do some further research that we'll talk about later on. The program itself, is this still me? This is still me? Okay. We changed this.
No.
Okay, that's what I thought. So we'll be talking a little bit more about the current study in a few minutes, but Damone's going to talk some more about what he does in the intervention.
Hello. So I'm the intervention person known as the treatment education specialist. So when they come to see me, it's basically it's a two-phase program. So phase one, basically I see them for at least every 2 weeks within a month, and then phase two is like a model just to see what's happening, the follow-up for 2 times. And what's interesting about being the intervention specialist and working with these individuals is that, especially in phase one, I get to know them I get to understand them, who they are, their experience. And ever since I've been to LA and working in the community of HIV and AIDS, I've always heard about the gay man's story, and I've always seen about the gay man's story. But when I speak with the women that are in this study and I hear their stories, these are women that has been positive since the 80s, since the epidemic was around, and they share their story. I'm learning from them, and I'm learning how I can help them, especially with the information that we have today. And these are their stories that they're sharing, and when I connect with them and they feel like when I can check in with them when they come and I can check in, how is the family, how is the husband, how is the children, how is the grandchildren, they feel welcome. It's not just about your client, and this is just client and partners relationship. Like, no, I let them feel like we're one, we're friends. So I find that when we do that, they open up, they talk, they're willing to talk about their stories more. And so we have to use motivational interviewing, and we know that working in the field, we want to tell people, do this, do that. And that has been the cases where doctor says, you have to take this, you have to do this. But at the end of the day, sometimes people are not compelled to do it. And if you tell somebody to do something, they're going to do the opposite. So guess what? It's kind of like you're tricking them to do what you want to do, and in order for them to do it. So, and we find that people, when you ask them what do they want, what do they want, what do they expect? And one of the things that I'm getting most is that they said that they want to live. They all said that I want to live. And that's one thing that they said. And because they want to live, they're willing to do what it takes to make them live. And throughout the years and throughout the history of the black community, we know about it. Some of them, they weren't around, but guess what? Somebody told them about Tuskegee. Somebody tell them about how black people has been used as lab rats and stuff like that. So these are concerns. These are real issues. Discriminations do exist. We know we can try to hide it, but guess what? People feel as if because of their skin color, they might not get the services that they deserve. And they feel as if because of their skin color, the providers are not giving them 100%. So therefore, we address within this, being the motivational interviewer with them, I address some of these issues. I try to pull out some of these issues that they encounter so we can find a way how we can overcome these barriers, or we can overcome these issues. And this leads to mistrust. Because guess what? If they say they don't trust you, most men too, they don't like to go to doctors because of what somebody told them, because of what happened, because of what the history has said. And so we are here and we're trying to change that. And working part of RISE to being part of this team, it kind of, when they can see somebody who looks like them and represent them, then they're willing to listen and they're willing to open to have that conversation. And we have to address the mistrust, because at the end of the day, if they believe that they're not being heard, then they will not do what they're supposed to do. And one of the things with being in this position, sometimes I have to take risk with these clients, because sometimes I have to push their button. For instance, one person has said to them, do you think that you might need to talk to a professional about what is happening? You know what their response was? What? You think I'm crazy? You think I'm mad to speak? You want me to speak to a psychiatrist? You understand? But that's not what we're trying to do. So sometimes I have to take risk to hear their expression, to hear what they have to say. And that's part of my job. And then once I say something and if like, oh, you're pushing it too far, then I step back and then I apologize. And then I ask them, where do you want to go? Where can we go from here? And that's part of the job. And so far, it has been rewarding for me, rewarding for persons who have been participating, because one of the things that some of them also want to do is to disclose to their family, because living with HIV for so many years, but their family do not know. So. Good morning, everyone.
Good morning. All right, I like that. So in our first Project Rise, we recruited 215 participants, or people, 107 in the intervention and 108 in the control. We recruited with various ways of recruitment through flyers and presentations, to staff and clients, through about 20 relevant agencies throughout LA County. People were eligible to be in the study if they were 18 or older, Black, African American, on ART, self-reported adherence problems, so basically kind of missing one dose at least in the last month, or the past month, and or a detectable viral load. Willing to use an electronic MEMS cap, which you will see shortly, and not in any other adherence study. Here you will see a picture of a MEMS cap, basically which means the Medication Event Monitoring System, or MEMS. Basically, we would use this data, we would collect the data, we would get the cap from the people, and we would read this cap basically at a month and a half, at 3 months, 4.5 months, and 6 months post their baseline visits as well. The past 2-week adherence was calculated at each time point, and then we would also adjust for cap use. Basically, if a person is supposed to open their bottle twice a day, but they only opened it once a day, and they took multiple pills out, so we would adjust for that. Here is basically what we would see when we actually use the MEMS cap. So we would put the cap on a special reader, and this is what I can see with the participants. So if they open the cap, let's say this person is supposed to open the bottle once a day. So you'll see where the green numbers are, that person opened the bottle once a day. However, if they did anything different from that, it would remain yellow, and I can actually see if they didn't open the bottle, looking at the zeros, or if they opened the bottle twice a day. One time I saw somebody open a bottle 15 times a day, and I'm like, what's going on? And because we actually tell them we're monitoring only one HIV medication, and the bottle was open 15 times a day, and she explained, oh, I have my aspirin and HIV meds and my fish oil pills. I said, okay. So we had to go back and to say, okay, we're just trying to monitor one pill a day to get her back on track. We're switching over.
Okay, so I'm back to tell you a little bit about the data from the first Project Rise that we did. So this was before, now we're doing another one that we'll tell you about in a moment. And from this, these are the participants who we recruited, the 216 participants, and they were about 50 years old on average. About 3/4 were male, 64% were sexual minority, meaning gay, lesbian, bisexual, or something else other than heterosexual, and relatively low socioeconomic status. About 20% had less than a high school degree, about 2/3 had less than $10,000 annual income, and most were not working on disability. 30% were not stably housed, so homeless or temporary housing, and 55% had ever been incarcerated in their life, and they had been diagnosed an average of 15 years, 16 years. And finally, the baseline adherence that they self-reported was that they took about 80% of their pills on average in the past month when they entered the study. And we also calculated how many took at least 85% of their doses, because that's seen as a marker of good adherence and related to viral suppression. And we found only about half had this marker of good adherence. So here are some of the results. So we showed a large effect on adherence. So you can see the blue line on the top. You can use this. So those are people in the intervention group over time, starting at baseline before the intervention and then going for 6 months to right after the intervention. And what we found is pretty steady adherence among people in the intervention group over time, and steady good adherence. So there you see high levels of adherence, at least 85% of pills taken over time for people in the intervention group. But people in the control group, we saw a different story. So we saw people in the control group actually declined in adherence over time, and that's the red line. Oops, didn't mean to do that. So yeah, as you can see, the steady decline over time in the control group. And we see that in a lot of our studies, where we just measure people over time in the absence of an intervention, that adherence tends to go down over time. And what this meant when we looked at this statistically is it was a very large effect, and larger than most adherence studies have shown. And the large effect was really due to keeping people in the intervention to be adherent over time, a stable level of adherence, whereas people in the control group were going down over time. And a different way of looking at this is with this graph. So focus on the first set of bars here. So that says stayed non-adherent. So people here, the red bar is intervention, the black bar is control. And these are people who stayed non-adherent for the entire study, for all 6 months. So when we look at it, we can see a big difference between the intervention and control group. So the intervention group was much less likely to stay non-adherent over time than the control group. So you can see a very high black bar, meaning that people in the control group were mostly staying non-adherent. Then we looked at the pattern of people who were non-adherent to adherent. That's the second set of bars. And so those are people who started the study as non-adherent, but then they got adherent over time. They moved to become adherent over time. And as you can see, there's an opposite pattern here where people in the intervention group were much less likely to go from non-adherent to adherent over time, and control group participants were not likely to do that. And that's the low black bar. So now we look at people who stayed adherent, which are this set of bars, a third set of bars. And what you see is that people in the intervention group, the red bar, were more likely to stay adherent over time, which is what I showed in the last graph as well. But people in the control group were much less likely to stay adherent over time than people in the intervention group. And finally, look at this pattern, adherent to non-adherent, the last set of bars. And so these are people who started the study as being adherent to treatment, but then over time they became non-adherent to treatment. And when you look at these bars, you see that intervention participants were less likely than control participants to reduce, to become non-adherent over time. So thank you. I'll let Matt talk a little bit about what these results mean.
This is kind of like a pause slide. It's sort of like, it works for the teacher and me because there's a lot of information that we covered. And the truth is, we've been doing this research for a long time. I think it's been 10 or 12 years that Laura and I have been working on this one project. You know, research can take a long time, and we can be sort of like the turtle in the race. But sometimes the turtle wins the race, right? So, you know, we focused on this issue for many, many years, and it's still relevant. It's still relevant to be helping people become adherent. And what Laura had showed in the previous slide is that in our previous study, those folks in the intervention were more likely to go from non-adherent to adherent and also to stay adherent. So it was a really promising intervention. And it resulted in superior adherence. That was statistically significant. And we do have a paper here that provides a result, so I believe Wen is going to put up on the website. But it did show a positive result. And so that was used to then go back to the National Institutes of Health and ask for a full R01 study, because the truth is that they and other agencies like CDC really want to see a biomedical outcome. So they wanted to see not just adherence from MEMS, but viral suppression as the outcome, which involved getting lab work done as part of our study. Because even though we tried to look at their lab work in the previous study, it didn't always line up with our assessments periods, if that makes sense. So we couldn't necessarily correlate the intervention with their lab work from their own doctors. So we got this additional study to really look at the intervention and the effect on viral loads. So we are now doing lab work as part of the new study. Yeah. So the new RISE 2.0, we went back to our CAB. Our CAB wanted to keep the name. They felt the name was good and it had good recognition. So we're keeping the name for this study, but it's a new study based on the same intervention, but with the different outcomes. We also strengthened the manual to really integrate motivational interviewing into each component and each issue that we're addressing. We also are looking at the assessments over a longer period of time. So this time it's going to be up to 13 months. So we'll have more data to see the impact of the intervention over a longer period of time. In addition, we're doing a cost effectiveness study, and that's another thing that is desired out there for if we're going to roll out the intervention, if in fact it does show that it's effective for this biomedical outcome and we're able to roll it out, we will also have cost effectiveness data. So we've added some elements to the study, but just in case anyone's having deja vu, we did RISE before. And so we're basically doing it again, but stronger and even more rigorously this time around. I was trained to stay at the mic until the next person's there, so that's why I do. Okay.
All right, so now we're talking about RISE 2.0 as well too. So this time, as Matt and Laura said, we're recruiting a larger amount of participants, of people. So we're looking for 350 participants to be in the study, 175 in the intervention, and 175 in the control. I've left these are lovely RISE. I have to plug our study. So I've left a few of the cards on some of the tables as well too, and some of the information is also on the back, but I believe you all have some in your packets. People are eligible for the study if they identify as African American or Black. Multicultural is okay. They have to be 18 years or older. They have to be HIV positive. They have to be prescribed medication in the last 6 months. And this is slightly different from the first study because in the first study they had to be on ART. This time they have to be prescribed medications because if they're not taking the medication, these are the people that we actually want for the study, to help them get back to adherence. So this is slightly different. They have to be prescribed medication within the last 6 months. Self-reported adherence issues, once again, not taking the medications properly and or detectable viral load. So those are the eligibilities for the study as well too. And as you see, this is our lovely flyer as well too for the study. This is I call this the show me the money page. Because we know I love the participants dearly, but sometimes the first question is, how much am I getting paid? So this is the show me the money page. Everybody in the study, control or intervention, can earn up to $230, and we give actually in Target gift cards. Okay? Yes. And in order to get the $230, people should be doing the following. So they have to do the MEMS data, so the electronic cap that I showed you before. They have to do 3 surveys at least. Their baseline survey, post-survey at 7 months, and a post-survey at 13 months post the baseline. We're doing, as Matt said, we're doing 3 blood draws now. So at their baseline, right before the intervention, at 7 months and 13 months post-intervention as well too, to test their viral load. And they have to do 4 check-ins for adherence and contact information. Now, people in the intervention can make up to an additional $90 in Target gift cards, doing $10 per session if they do the 5 to 9 sessions with Damone as well too. Man, I think it's up to you. Oh, yes, I will do exactly what Matt did. I will stay at the podium until somebody else gets here. Yes.
I learned that in Toastmaster because you don't want an empty podium in your video, right? Right? We're kind of doing this one together, but actually we're going to all be, I think, having a discussion and answering questions. But I think just to kind of reiterate, the next step is for us to determine the long-term intervention. And so, effects. And so we're here to both kind of share what we've been doing, but also to ask for your help in recruitment. We are on the ground, and we have recruited 39 participants so far, but we have a long way to go. And we're really open to collaborating and working together with you all on this project that, once again, will help all of us meet our goals. for 2022. So we have some discussion questions here, but actually I think they're going to be open to everyone. I don't know how long we have, but I'll leave that to the moderators as far as how long we have. I know we
have
ended
about
up,
10 minutes.
Okay. I know we ended up telling some stories and so forth, but we have some possible discussion questions here about, that we're interested in, like how RISE might be best disseminated down the road, and also recruitment strategies that people might suggest. But obviously you all might have some other questions or feedback or just issues that you'd like to discuss over the next 10 minutes. So we welcome your questions.